Thank you all again for having me. Dr. Juan Andino. I'm at primarily at, actually, I'll show you, at UCLA, about 4 days a week, Tuesday through Friday, but also down on Mondays, I'm at MLK Community Healthcare down in Compton in the Wilmington Clinic. I'm going to put this up for a second. The slides will be recorded. I don't know if I've shared the slides with Kathy, but I can also share it with the group, and I'm, very fine with this being disseminated. But here's the two office locations that I work out of. Two different phone numbers, one obviously in West LA, Santa Monica, Compton, a little bit further south. And I'm trialing this. I wanted to offer it to this group first and see how it goes. Sometimes particularly on the big academic health system, the phone tree side can be a little bit of a miserable experience. And people, I think, get lost in that process because they don't have a dedicated call center for kind of men's health versus oncology versus female health, et cetera. So if any folks, after hearing the talk today, if this is something that you're looking to have a more formal consultation one-on-one, I've created this separate email. Feel free to reach out with this info, name, date of birth, best contact number, and I'll do my best to internally try to get my office, my folks to reach out to you and help get an appointment. But what are we here to talk about today? Well, erectile dysfunction is the first part of these chats that I have with patients in clinic. We know that prostate cancer survivors, whether you've had surgery, radiation, hormone suppression therapy, chemotherapy, will not only help treat the tumor and the disease, but can also have side effects. And one of the very common ones that we see is ED or erectile dysfunction. And definitions are always nice to be on the same page. It's this persistent inability to achieve or maintain an erection that is firm enough to perform. And I always like to add a word here, satisfactory sexual activity or sexual intercourse, because sexual activity and sexual intercourse can be very variable, couple to couple, relationship to relationship. And in general, even before we're thinking about prostate cancer, how common is this? Extremely common. About 20%, 20 to 25% of men, some studies up to 1 in 5 men age 20 and older suffer to some degree of ED, and I'll have some numbers specific for the prostate cancer survivorship world. There is a component of aging, but obviously we know that prostate cancer care impacts this very specifically. And taking a step back, well, what is the erection process? It's always nice to kind of nerd out about this. Well, we know that with arousal, the nerves around the penis and that travel around the prostate kind of are the first part of the pathway. They initiate the signal for an erection. That as the nerve signaling kicks off, the muscles within the penis in this area down here, they actually relax. They're called smooth muscles, and that opens up the blood vessels so that there can be better blood flow into the penis. As that blood flow comes in, this kind of spongy tissue you can see on the image here on the left, go over here to the right, it actually engorges, it fills with blood, and the blood is intentionally held there, trapped there, in order to help maintain that erection and maintain that rigidity. In fact, on purpose, the body actually squeezes the veins within the penis shut so the blood doesn't leave immediately, and that helps the erection be maintained until orgasm. And then after the orgasm, the mechanism kind of reverses, the pressure goes down, the veins open, and things are able to drain. Well, what happens, and I'm going to focus here on prostatectomy, but then I'll mention that radiation can have some similar effects. What you can see is that if a man has prostate cancer surgery, they undergo removal of the entire organ the majority of the time. There are some focal treatments that are gaining some use and some safety nowadays, but many men still, the gold standard is either surgery or radiation. The prostate is removed and the nerves are often able to be peeled off or preserved, what's called nerve sparing, but all of that can put pressure, tension, damage. The term we use is neuropraxia. It in some way stimulates or can injure the nerve even if you preserve them. And so we do expect there to be some changes in erectile function, at least in the short term. And so we do see that in some men, especially with the robotic procedures and with the nerve sparing procedures, that some men may be able to get back to kind of their previous pre-treatment levels of erectile function, but it'll vary. It may take up to a year. And while we know that with surgery, a lot of these changes kind of occur up front, with radiation, some of the newer studies suggest that somewhere in the 3 to 5 year range, you're not going to see this upfront hit that happens with surgery, which then recovers. With radiation, the process may look or feel a little bit different. It may be that up front, there's really not much of an obvious change, but over a period of several years, the male aging process is going on as well. That erectile function and that erectile response to, for example, Viagra or Cialis may also diminish. And this is just a nice reminder that there are many things that can impact erectile function. Obviously, we're here in a prostate cancer support group, so that's the number one thing that I'm focusing on. But a lot of things in medicine are multifactorial, meaning we have kind of a prevailing area that we think, okay, this might have been the cause of the impact, but things like getting older, just increasing age, we know affects erectile function, smoking, diabetes, heart disease, or high blood pressure. All these things can work together and worsen the severity of the erectile function, and whether or not men can respond to kind of what we call first line therapies like the Viagras or Cialis of the world, or if we need to go into more advanced therapies, which I'll review here in a little bit. And you can just kind of see that in general, big picture, the majority of ED actually that we treat is considered to be vascular in nature, and that tends to be primarily associated with aging and then cardiovascular disease. Diabetes is the next big population. And then you can see here that about a little more than 5% of patients are due to some sort of pelvic surgery or trauma like cancer treatments. And I always like to mention to folks who come in to chat about this, it's one of my favorite things to talk about because it's one of the things that in the world of urology, we have the most treatment options for. And so I very comfortably can tell people, look, if this is a important part of your life, of your partnership, of quality of life, we can get there. We kind of have an entire toolkit of things that we can trial and error together. But there are things that range from as non-invasive as pills to surgery, which we'll talk about in a little bit. Interesting, and it's to me this number is shocking and so important to say out loud. A quarter to three-quarters of men who have a nerve-sparing radical prostatectomy to treat prostate cancer will have some degree of ED afterwards. So you can see that it's a huge range. The starting place where the sexual function was before going into surgery matters. But even on the other side of that, there can be huge variability of what additional treatments may be needed. And the thing is that this ED can persist. And so we can see, we know that if we wait, if we treat with things like Viagra, Cialis early on, what we call penile rehabilitation here at the men's clinic, that we may speed up the time to recovery. But if somewhere within a year, 9 months, a year, there's still an ongoing issue and ongoing changes, it's probably worth having a nice sit down and reviewing what are other options and what are other alternatives. And so let me jump into some of those. And this is not going to be fully comprehensive because I want to make sure that there's some time for questions. But I like to kind of mention and touch upon the kind of workhorses of erectile function management. So obviously the first line therapy, I've already hinted at this a few times, are oral therapies, pills. The medical term is PDE5 inhibitors. That's the type of enzyme that they work on. But these are the Viagra or sildenafil. That's the generic name. The generic versus brand does seem to work very, very, very similarly in patients, or Cialis, tadalafil. And these, combined with sexual stimulation, which is key, can help produce an erection. Sometimes folks ask me, well, if I just took the pill and I sat on the couch, nothing happened. Without any stimulation, nothing will happen. It's that initial foreplay stimulation that's required. And importantly, the pills require the nerves to be functioning, at least to some degree, because they really rely on amplifying the nerve signal to help open up the blood vessels to stimulate an erection. That's why in some cases, after either surgery or radiation or other forms of pelvic surgery or pelvic trauma, there may not be a response with the medications, because if the nerves aren't able to provide enough signal, no amount of pills that we add on is going to help overcome that. They can have side effects, headaches, flushing or congestion. With Cialis, more so than Viagra, some guys can get an upset stomach or some reflux, some heartburn. And importantly, if someone has to take a nitrate medication, and the most common one people hear about, nitroglycerin for heart issues, these are not great to mix. There's very specific nuanced situations in which we can talk about it, but kind of in general, it's good to know that those two don't work together. That's why the commercials, in the bathtub always end with combining these can result in an unsafe drop in blood pressure. Am I doing on time? Not too bad. Intracavernous injection therapy are some of the next line things that we often use. These are medications. You can see from the graphic picture here, but this is my day-to-day, my week-to-week medications delivered directly into the penile tissue. They bypass the nerves. And so as opposed to the pills, which require the nerves to be functioning, firing on all cylinders, these medications are great options for men after surgery, after radiation, or just the pills have faded their effect over time because they skip the nerve part. They actually go straight into the tissue inside the penis and help open up the blood vessels to promote blood flow. As you can imagine, it's a little bit more involved than just taking a pill. There's an actual needle. I will say probably 90-95% of men tolerate this very well when we do a teaching in the office. The fear of an injection going into the penis tends to be more of a barrier than pain itself, but there is a needle going in, and the medication, about a third of men can have kind of a burning, aching sensation with it. So it's not for everyone. Importantly, we often provide a lot of guidance, even though some of these now people can buy online. But if used without guidance, there's actually a risk of a priapism or a prolonged erection, an erection that goes on beyond 4 hours, which sounds great up front, but actually beyond that 4-hour mark, there can be permanent worsening of the erectile function. And there's some patients who get into an even worse state where now really the only option is surgical therapy and none of these other things work. Logistically, functionally, why do many people not use injections long-term? Cost. They're usually not covered by insurance. We work with compounding pharmacies to help patients access these in a more affordable fashion. They can be delivered to your home as long as you're within the state of California. But over time, the fact of having to do an injection every single time prior to sexual activity may not be a long-term relief for all patients or all couples. And lastly, one of the hallmarks of the prostate cancer survivorship world, it's surgical, but it's called a penile implant. I think it's blurred out, but that's exactly what's over my head there here in my office. This is the inflatable penile implant. It's a mechanical device that lives completely within the body, particularly for the more advanced forms of erectile dysfunction, or just for the man who desires spontaneity, control, to kind of remove all these pieces of cost and planning and frustration. The surgical therapy is a very good guideline-directed option. The best comparison in the world of medicine of surgical therapy is a knee or a hip replacement, meaning I think about this as a functional surgery. This is not cosmetic. This is not for show. It's truly a surgery designed to restore function after cancer treatments. And because of that, most insurances will have some coverage for it. There's certain plans or certain employers who've carved out an exemption to just not pay more. But overall, there's growing coverage for this therapy in the United States. With any surgery, we think about pain. With any sort of implant, the biggest risk, the biggest factor we worry about is infection. And I'll talk about some things that we do to reduce that risk. But, obviously, any sort of surgery is definitely an investment and requires a good sit down to hear the pros, the benefits, and the cons, and make sure that, for the individual patient and couple, that pro category outweighs the now lower risk compared to older devices. There are multiple components, so mechanical malfunction or failure down the road is very important. The average lifespan of these devices is about 10 to 12 years, and less so for the inflatable, more so for the malleable, but for both types of implants, it can erode, meaning that it can kind of over time, especially for patients who have diminished sensation or spinal cord injury, something else going on, If the device is left inflated for a long time and it's not in that kind of softer, more natural state, it could potentially kind of keep pushing through the tissue until you could see a little fragment of it. But that's quite rare in patients who have intact sensation. You can see down here, there's several different types of implants, but for one specific, that's probably the one I do the most often, the Boston Scientific device. When they've surveyed patients who underwent the surgery, a high percentage, 97%, would recommend it to a friend. And interestingly, when they ask folks, any regrets, do you wish you would have done this sooner? Many folks do mention that they wish they would have done it 5 to 6 years sooner because it would have provided that spontaneity and that feeling of control back. Now, with the newer devices, the key is that they have an antibiotic coating, and that's been shown to really drop down the infection rate to about 1 to 2%, which is much, much lower than 10 or 15 years ago. It has a pump. You can see it there down in the scrotum. This is all under the skin, not visible from the outside, but basically when it's go time, man reaches down, feels that pump in the scrotum. They quite literally pump it up so that the cylinders get rigid. And then you can see it has this little button here on the center. You press that button, and that allows for the deflation. So the fluid that's in the cylinders through this three-piece device actually goes back through this tubing and goes back into this little balloon that's inside the body so that you can have a natural flaccid or soft appearance when it's not being used. I'm going to pause here for a second, and then I'll jump in quickly into the incontinence side before we have some time for a Q&A. Again, I'll make sure that this is available for you folks, but this is a series developed by one of the companies that makes the device. But I find it really helpful. Patients have given me very positive feedback because while in the office we can talk about risks, benefits, the surgery itself, recovery, how much time off work you need to take, etc., this series is really designed to help capture the patient voice and why do people pursue surgical therapy for ED and kind of how it has benefited them or their partnership, et cetera. And so kind of in that testimonial side of things, hearing the real world lived experience. I think this video series and this QR code is very helpful. And in fact, their website even has a way to connect patients to other patients who've previously undergone therapy to talk about what was it like, how did they recover, what helped them make the decision, et cetera. So now let me switch gears a little bit. The other aspect that I talk to folks about and see in my practice is stress incontinence, leakage of urine. And this is primarily now focused on the prostate cancer surgery patient, the prostatectomy patient. There are other types of incontinence that could occur with radiation, but those are treated a little bit different. And in this case, we're talking about the type of leakage that occurs when a man lifts something heavy, coughs, laughs, with physical activity, there's uncontrolled leakage or loss of urine that requires wearing either pads or a diaper. And we see that about 17,000 men in the United States develop this type of incontinence, what we call stress incontinence, and it affects a high number, millions of men worldwide. And the majority of these men that we treat and see are after prostate cancer treatment. This number, importantly, has gone down significantly. While ED rates after robotic surgery are still very variable, that 25 to 75% we discussed earlier, the incontinence rates have dropped down significantly, and the more modern series show that about 10 to 15% of men, about a year out after their prostate cancer therapy, are still having some leakage of urine. But this 10 to 15% is still quite significant, and there can be a huge variability, whether it's mild, a light pad once a day, or the person who's changing 5, 6, depends. And on both ends of that range, there can be a significant impact on quality of life, comfort. Does someone feel okay leaving their home, going to social events, the worry about the smell of urine, et cetera. And so I find this a very important issue to be able to discuss and normalize. And so immediately after surgery, there are many things: planned bathroom breaks, drinking a little bit less fluid, particularly before going to bed. Things like pelvic floor physical therapy can be incredibly helpful to try to restore and regain some control over the urine. And then there's the coping strategies, like I mentioned, pads, diapers, catheters. We really try to avoid as much as possible, that there can be some risks associated with that unless, in specific circumstances, penile clamps. But what happens when this is ongoing? It's been 6, 9, 12 months after surgery, and there's still bothersome leakage of urine. Well, there's a couple of different treatment options, and it depends on the severity of the leakage. But one is a sling. So this is a um, device that is placed in the operating room. It is a surgery, but it doesn't require any activation by the patient. And for the milder forms of stress incontinence, it can be a less invasive procedure, about an hour, hour and a half. And in many studies, it can show up to 80% reduction in pads. A few men are bone dry, but in general, more of what we can achieve is a significant reduction in the number of pads or amount of leakage that's taking place in a day. And what you can see here is the structure of the sling or of the device. There's basically an incision below the scrotum, under anesthesia, of course. And this hammock helps put pressure under the urethra. So that area that used to get a little bit of benefit from the prostate being in front of it now has changed anatomically after the prostate cancer surgery. Well, this sling can actually help be an external force of pressure to provide a little bit of additional control and resistance so that with motion, laughing, coughing, etc., the urine isn't just freely leaking out. And then there's also something called the artificial urinary sphincter. This looks a little bit more like the penile implant in that it's a three-piece device. It requires patient activation, but it really is the gold standard for the more severe forms of incontinence. The person who's changing multiple pads in a day, the person that just standing up, just doing this results in loss of control of the urine. The artificial urinary sphincter is going to provide a much more successful response in terms of being able to provide some control over that urine. And a lot of words on this slide, but I'm just going to talk through it real quick, and then we'll have time for a Q&A. See, that's three pieces again. Similarly, there's a balloon that holds some fluid for pressure, but here now, instead of being in the penis to help provide an erection, the artificial urinary sphincter hugs the urethra and provides a kind of constant pressure when you're walking around, when you're living your day-to-day life. And then this control pump, when a man squeezes that pump, it actually helps that cuff open up, relax, loosen up so the urine can escape when a man's in the bathroom. And then over a couple of minutes, that pressure builds back up and it helps close off the urethra and provide that support. So it can really restore that aspect of urinary control, even for the more severe forms of incontinence. And here there's a little bit more data. This has been around for many years. 90+% of patients report high satisfaction. Many people go down from multiple diapers to using no pads or one pad per day. And so especially for the more severe forms of incontinence, this can be a great option. Similarly, there is a QR code and a link here for a quick assessment that if this is something that you've dealt with or that you've been experiencing, that can help provide some guidance as to whether it's worth, chatting with someone. My ego's not in this. If someone's closer to you that offers male slings or artificial urinary sphincter, it's just a very important thing, in my opinion, for patients to know that is an option. Because many times the focus is on cancer, 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 cancer. And then we get the luxury to talk about quality of life things. But oftentimes I find that this discussion about the ongoing leakage or incontinence, if someone's not directly asking a patient, can kind of fade to the background. And so I've met many folks who have been, for lack of a better term, suffering in silence for years because they really weren't aware that beyond pelvic floor physical therapy, some lifestyle modification, that there were other treatment options. So once again, those are the two sites. I know a couple of folks joined while I was talking and reviewing some of these slides. These are the two sites that I work out of, UCLA, the men's clinic, as well as on Mondays, I'm down at Martin Luther King Community Hospital, operate there one day a month. On the UCLA side, I operate a lot more frequently throughout the week. These are our office phone numbers. And again, if any interest in having a consultation in this, you can call these phone numbers, but also I'm going to do a little trial to see if folks reach out to me through this directed email, if I can help expedite that process at all. And with that, yep, that's my last slide. Let me pause there and open it up for questions, Q&A. I can leave this up in the background for now while we start chatting.